right, so we are here with Dr. Michael Burke. Dr. Burke, thanks for coming.
Thank you very much.
With us, sharing some of your wisdom and intellect.
Do the best I can.
I've known you for several years, and I have the utmost respect for you and your clinical judgment.
Well, thank you very much.
So why don't we start by telling everybody a little bit about yourself, your background.
Well, I went to medical college at Georgia. Actually graduated 30 years ago this year, and was at Duke for residency. Also did a fellowship in research there. Had the opportunity to work at the University of Miami for a number of years. That was where I got started doing geriatrics, and I was part of the Geriatric Research Education and Clinical Center at the VA, where we were doing some research projects in geriatrics, including in cancer and prostate cancer. That followed up with coming here and being at the VA and at Emory. Also had a chance to work with both cancer patients, and most cancer patients happen to be geriatric patients. We also had an inpatient unit at Emory that took a fair number of geriatric patients. I've done a fair amount of psychopharmacologic research, and was fortunate enough to get a board certification as well in psychosomatics as well as psychiatry, and had a fun time also with telehealth.
Yeah. So when you mentioned geriatrics, that's kind of what we want to touch on today and kind of give some information, and and this will go out to nurses, NPs, even psychiatrists who are interested. Obviously some individuals shy away from specific populations. Some do not like children. Some have a hard time dealing with geriatrics. Why do you think you tend to gravitate towards geriatrics so much?
I think the geriatric population is very interesting for a couple of reasons. One is that it's a place where medical illnesses often interact with their mental health, and a lot of it is because the brain is sometimes the harbinger for issues that are in the body, so that you look at patients that come in with mental health issues for geriatrics. Often it is due to medical causes, and being able to understand that the brain is simply part of the body provides us a nice window into diagnostic opportunities. That was one of the things that we did in behavioral medicine / psychosomatics, was being able to identify mental health issues in patients, go to see them, and then find that they might have a number of different medical diseases, and it had nothing to do with depression or schizophrenia or other more traditional mental health issues.
Do you think that medicine and science are coming closer to realizing that you can't separate the brain from the body?
I think that one of the issues a long time ago ended up being the sort of fancy way of talking about Descartesian dualism, that there was a mind and a body and that they were somehow separated. The interesting thing is, after trying to think about that mind-body problem for many, many years, I started to realize that the brain was body. Mind is matter. There might be secondary storage out there. I'm going to leave that to the theologians and the philosophers, and work with the idea that the brain is where we store a lot of the behaviors that we do.
Right. Okay. So one of the topics I think of interest, and just let the viewers know, we've had some nurse practitioners that we work with here who would write in and give us suggestions on questions that they may be interested in, and I wanted to pose those to you to see if you can give some guidance and clarity.
Sounds great.
I guess one of the things is, what do you see as the biggest challenges in treating the geriatric population? Especially, I know you did some teaching for quite a while as well. how do you tell students, okay, look, these are things you may need to be concerned about. These are the areas, things like that.
I think a couple of things to think about in the geriatric population. One is that these are, when you come down to the parts of what's important, one is that they're people that have stories. They have often extensive histories because of their age and experience. And so making sure that you understand that a lot of times geriatric populations, other people talk for them. They're often not able to give their own story, to make sure that you sit down with them and hear what they have to say. Often that's also going to be the best way of doing a diagnosis as well, because if you're listening only to somebody else, you're not getting a good mental status exam, which is the basis of our examination in psychiatry to understand what's happening to a person, whether it's their speech patterns, whether it's their thought patterns, the prosody of their speech, whether it's cognitive abilities or disabilities that are occurring. Those all come out while we're doing an exam with the patient.
Right.
The next part of looking at the patient is to understand that their biology has changed over years. As the body gets older, organs slow down. We rarely ask our geriatric patients to run across a hall. Even when we're doing a stress test, the cardiac stress test, we don't usually have them on the treadmill going full speed. And yet we'll give them a full dose of certain kinds of medications. Their legs might be a little bit slower, but so are their kidneys and liver.
Right.
And so understanding those changes, what has changed and what hasn't changed, is going to be important in not only diagnosis but treatment of these patients.
So with treatment in mind, obviously you're encountering a lot of different medical complications and comorbidities with these patients a lot of times. And mental illness, sometimes it's hard by self-report. They can't tell you an accurate history. So, in some ways you have to be a detective as well and kind of get resources, reach out to families if they have any, to kind of get a whole picture of these patients.
I've always talked about that psychiatry is, when done well, is probably as much detective work as infectious diseases when they're doing it with public health. That to really figure out what's going on with somebody, you have to go to multiple levels to make sure that you understand what's occurring. And I think you, as you point out very well, that sometimes the mental illness will interfere with their ability to describe their case, no different than in forensics. If the patient has passed away,
right,
you have to look for other clues.
Right.
In that, we get to the point where we both understand what's more likely than not in a particular population. So, as an example, frequently elderly are misdiagnosed because they might show mental health symptoms. Let's say psychosis as an example, where they're seeing things or hearing things or believing things that are unusual. It's important to realize that in the geriatric population, especially somebody who has had a long history of mental illness, that it might be their mental illness. However, if it's somebody who's 75 or 80 and they've never had mental illness before, the likelihood that it's mental illness in the traditional sense of depression, anxiety, schizophrenia, bipolar illness is less likely, especially if it's very acute. And it's much more likely there are medical causes that might be driving those changes because, again, the brain is going to be affected by changes in the body.
So I've often heard you say in working with you that New onset psychosis in, say, as to your example, a 75-year-old individual with no previous history of any mental illness. I think you always say the top 10 reasons are physical.
Yeah, the differential diagnosis for psychosis in the elderly is medical, 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 and then you can start looking at other things.
What do you think is typically, because I can relate to a family member who had a very severe UTI, and it went untreated, and they started having altered mental status. But when they were treated, it resolved. How frequently do we see this? It would seem like it's pretty common.
It's extremely common, and one of the things that occurs with patients who are elderly, they will get psychosis, and they will often get misdiagnosed as, somebody says, new onset schizophrenia, which typically is near impossible in an 80-year-old or even younger, or they're diagnosed with dementia and they're pushed to the side without a good diagnosis. But in the understanding of the brain and how it works, infection and any kind of inflammation can do a number of things to the brain. One is that the body can get a number of basically biochemicals, whether it's certain kinds of inflammatory agents that can have an effect on the brain. The other is that there's a very powerful place structure that protects the brain called the blood-brain barrier. Mm-hmm. The only challenge is when there's inflammation, it opens the blood-brain barrier, so to speak, to larger molecules, larger protein molecules, drug molecules, and other things that shouldn't go into the brain that do. And once those go into the brain, they can have a tremendous effect on how the brain is functioning, including getting new onset psychosis.
So just to illustrate and trying to help my understanding, so if I'm taking a certain medication at a certain dosage, I've been taking it for a long time, I get an infection or something that alters the blood-brain barrier, does that mean that the dosage is going to have a different impact on my brain?
Absolutely. One is that, in certain circumstances, that drug in and of itself, as you get infectious processes, including, for example, whether especially a UTI. UTI, of course, is not just the bladder, but the kidneys and the ureters. If those kidneys start functioning less effectively, there are a number of medications that will accumulate. Mm-hmm. So just the idea, forget about the blood-brain barrier for the moment, that drug accumulated because the kidneys weren't functioning as well. That increase in the dosage now has an effect on the brain, especially for drugs that are already past the blood-brain barrier.
So I could see how that would be very dangerous in lithium toxicity or anything like that. They could get to a toxic level.
Not even just lithium, but ordinary medications that are not commonly prescribed. Lithium is one of our mental health medications, mm-hmm. but you can take, for example, medications for pain. You look at, a lot of the geriatric population has pain because of arthritis or other issues. Well, those pain medications start to accumulate under certain conditions. The other is that medications that don't normally pass the blood-brain barrier, because of the inflammation and the changes in the blood-brain barrier, now those medications have gone into the brain, sometimes even trapped in the brain when the inflammation goes away, and it takes a while to clear a condition, which is one of the most common conditions for new onset psychosis in the elderly, is delirium. Delirium is defined as basically a fluctuating level of consciousness, and what often occurs in the hospital, which isn't terribly surprising, is that the doctors will come in and they will see the patient fine. Mm-hmm. But an hour later, they're not good at all, but the doctor said they're fine, they can go home. Their family is saying, but he's so unusual, he's acting weird. the
So it
nurses,
can happen like this.
it can, and the fluctuating levels of consciousness can happen within minutes, can happen within hours. And they also, at the same time, will get irritated or aggravated behavior. They can often become psychotic and not understand where they are. And they also start to lose cognitive functioning. Much of this is because of changes in certain neurotransmitters. Typical ones are dopamine and acetylcholine, both which, interestingly enough, affect two other illnesses that cause cognitive difficulties or psychosis, and that's dementias and schizophrenia or others. So it's the same neurotransmitters that are affected, but they're affected because of medical causes or drug induced.
So you bring up an interesting point with dementia. Obviously, most people have been touched one way or another with dementia. Talking to a family, I'm sure, is difficult, especially if there's not as much information about the course of what to expect. And obviously, I'm assuming that it's variable from individual to individual, the onset and the longitudinal pattern of it. But I'm just thinking, talking to a family and telling them that right now it's probably as good as it's going to get, and we're going to continue down a path of lessening functional abilities.
The biggest challenge, I think, in medicine in general, is to tell somebody that a family member has a chronic disease, life-threatening disease, or a disease that is going to be continually debilitating. That's not an easy task at all. And in that process, trying to make sure that you both understand what's happening with the person, but also understanding the context of the family and how they're taking care of the person and what they've seen, gives you an opportunity to, as they call, break bad news in the most compassionate way that also is the most educational.
Right. Yeah, I think, I don't know if we habituate to certain things we do all the time, but being mindful that this is the most important person that this family has, and just being mindful of how to broach that and not just be mechanical and robotic.
There was an excellent book that I used to teach from called How to Break Bad News, because interestingly enough, in the cancer center, often patients didn't fully understand what was being told to them by their oncologist. They would come to the psychiatrist for depression or anxiety, and from there we would often discuss what was actually happening.
Right.
And the interesting thing was it was broken down in some pretty nice steps. If you looked at the steps on how to break bad news, the first part of breaking bad news is just to find out what the person understands. What do they understand from this at this point?
Right.
And talking to a family and saying, what have you noticed so far? What do you understand? The second part is to find out how much they want to know. There are some people that say, I don't want too many details, I just want to know in general. There's some people that say, I really want to get down to understanding as much as you can tell me. And there are some people that say, I want to know almost nothing, you just treat. And it's important to respect that. And some of the times that's very personal, and sometimes it's cultural. There are certain cultures that like to have more or less information. The next part is to break down and understand the general illness and then be able to compare that to what the person is having at that point. Being able to know that doctors do not have crystal balls. We have no good idea of fortune telling. We are looking at averages, and it's important to give people an understanding of what could happen, but that it might be different depending on the person.
Right. So I guess it's kind of you're straddling a line of realistic versus optimistic versus maybes. So it's a lot of variables that go into how am I going to approach this. If I say this, will that increase motivation? Because obviously the brain is extremely powerful, and the power of positive thoughts, things like that. So I guess it's a fine line you guys have to kind of balance.
And the other is medicine is constantly changing. I lived at a time and practiced medicine at a time where if you were HIV positive and you got full-blown AIDS, you were probably dying in a couple of years.
Mm-hmm.
Then medications like the protease inhibitors and other medications came out to where I've known patients who are HIV positive who have lived 20, 30
Right.
plus years with that
Right.
Diagnosis.
Right.
Where they're making strides in Alzheimer's as well, which, just as an aside, dementia is not just one illness, it's actually multiple different illnesses, which is why they both have different courses, and it's important to be able to get a good diagnosis from what that might be, up to and including the idea that there are a number of reversible causes of dementia. People should look for reversible causes of dementia first, before you diagnose an irreversible cause of dementia.
So if you've got somebody, say 40 years old, would that be a very early onset? I think there's a lot of confusion.
That's an incredibly early onset. Probably there are some dementias that can affect people quite early, typically 50s. Some of the frontal dementias can affect people earlier. Lewy body dementia can affect people a little bit earlier and has a different course than Alzheimer's. And we now got a celebrity that had Lewy body that unfortunately met his demise by knowing that he didn't want to lose his mind, which was Robin Williams, which is one of the reasons why people are talking about Lewy body dementia
Right.
more now than they ever have.
Because most people probably have never heard of it until, him going through it.
Mm-hmm.
So switching gears just a little bit, going back to the nursing home theme, we work with a number of nursing home facilities throughout the state. And one thing they always ask is, what are the signs that we need to look for in patients who become either combative or they're very different from one minute to the next? And you touched on a lot of it that, well, we probably need to get a medical clearance first before we get too deep into psychological issues. What would you tell somebody that you got a new onset, say, just mood shifts, just fluctuates back and forth, and it's very unusual for the person, a very drastic change? What would you tell a nurse or director of nursing? Hey, we may want to think about this or look at this.
I think that even in your question, you touched on a lot of the important pieces that need to be examined, whether it's a person in a nursing home or whether they're on a unit or a medical unit. When people have acute changes that are psychological, whether it's mood, whether it is being unusual, whether it's being combative, having cognitive changes, memory or concentration, or getting to the point where they have a full-blown psychosis. One of the most important things is this acute or chronic? How fast did this happen? Things that happen very quickly typically happen from processes that can change quickly. So something like a fast, immediate onset of not being able to remember something or not knowing where you are is really unlikely to be a dementia process. The reason is that dementia processes don't happen all of a sudden. They happen gradually. Now, if somebody was having a gradual change and then something fell off, there's sort of what they call subacute, a little bit different. But, keeping it real simple, that kind of process clearly is acute. Wow, it happened all of a sudden. Last night, Dad woke up and he was just really upset and he didn't know where he was. Those are the kinds of processes that are important to look for that can change rapidly. And we know that people who are elderly can get rapid onset of infections because their bodies often don't fight infection until it's a little late. They can have changes in their organs that can be quite fast, whether it's an acute renal failure. Those are probably some of the most common urinary tract infections. Even oddly enough, and I would probably spend a few minutes trying to fully understand if there are any new research, but a lot of times, especially in nursing homes, people notice that impaction of severe constipation could affect mental status.
So that would make me think that you would look at their medications. Are they prescribed heavy doses of opiates or something like that that can cause severe constipation?
Well, and the other is you're looking for accumulation of medications because, interestingly enough, the way that the body works, and it's one of those things that again can happen acutely rather than chronically, is that the way our body changes a medication is it has what they call a half-life. You give blank dose that creates a level of 100, we'll just say nanograms per deciliter, and that happens. So you now have that dosage. Well, some number of hours later, which is a consistent number, that'll then be 50. That'll then be 25, 12 and a half.
So it's reliable.
And it's reliable, and it's called a half-life. The only problem is when you saturate the enzyme that is doing that, it then comes out in a quantity that's a fixed quantity rather than a half-life. So
it's like dumping.
Well, kind of. So what happens is, let's say their level goes up to 200, but the most amount that the person can pull out is 50. We saw it went from 100 to 50 to 25 to 12.5. Let's say 50 was the most that the body can metabolize at one time. Well, if their level then accumulates to 200, then the next time that the half-life comes, it's only going to be 150 and then 100, but by that time they might get dosed again. So now it's 250, and then it goes to 200, 150, and then they get dosed again.
So you keep going up and up and
so
up.
That's correct. And it can go up quite quickly at that point. And that's why these medications can accumulate. So it's one of the very first things we look for in acute changes in the brain. And the brain, of course, shows its effects through behavior, through concentration, through memory, through consciousness, through movement, through the person's understanding of the world, psychosis,
right,
and through their mood. That's how the brain shows when it's working well or not. So if something accumulates, what happens is it can affect the brain. So that's one of the first things we look for. The second thing we look for is the things that can remove those medicines, which are typically the liver and the kidney. If they're all of a sudden, maybe you've given the same dose of medicine, but that liver can only pull out 25, well, the medicine accumulated. Anyway.
How do you ever stay on top of this?
It's why you have to be more careful with the geriatric population. It's why you have to use medicines that have a shorter half-life. So there are certain medicines that have very long half-lives. We typically don't use those in the geriatric population because there's too much of a risk of them accumulating.
So, for instance, it would be a very rare occasion to give somebody a long-term injectable shot for psychosis.
It's probably...
You wouldn't initiate it.
Yeah, you definitely wouldn't initiate it, and it's typically less likely to do in the geriatric population. Or, for example, sometimes people use, it's not uncommon, especially with primary care doctors, a older person comes in and says that they're anxious, and they will give them a medication that we typically don't even recommend in older patients, but a medication like that's called a benzodiazepine,
Mm-hmm.
Ativan, Librium, Valium, Xanax, Klonopin. Ones that have a longer half-life can easily accumulate, like Klonopin, Librium, Valium, to the point where their half-lives become 50, 100 plus hours just to remove half of it. Well, you can imagine how quickly that can accumulate because you're dosing every 24 hours.
And so irrespective of what you do until the body clears that, you're not going to have a change in functioning?
Until the body can clear that, you can accumulate and then get a change in typically consciousness,
Right.
because as you can imagine, a medication that's supposed to calm you down can also make you sleepy or drowsy.
But I could easily see that if somebody doesn't recognize this, somebody who's not used to working with a certain population, then the thinking is, well, maybe they need more.
Well, and often the reason why they say that is because, I don't know if you've ever been woken up out of a deep sleep, but the first thing that happens when you get woken up out of a deep sleep is you have sort of a startle response, and sometimes even a regressive response. Hey, what's going on? Because you're having a hard time getting your cognitions clear. That can then happen in the older population where they give them something. All it did was make them more drowsy. And as you try to stimulate them, they get aggressive, which then makes them give them more instead of less of a medication that's already causing them a problem.
Right. So it could be a vicious cycle where they can never find an answer, but they're not looking in the right place.
Or a vicious cycle sometimes is the best case scenario. Sometimes it's a vicious spiral downwards.
Right.
And the patient gets quite sick until they either accidentally or on purpose will change that medicine, or somebody who's trained in geriatrics will say, oh goodness, we don't give these.
So you mentioned benzos. Are there any psychiatric drugs that, aside from like MAOIs and things like that, that you would not necessarily want to see, or you would give pause if you've seen an elderly person on?
Obviously, there are changes in medicine that made us take a more careful look in our psychiatric medicines of the antipsychotics. Some of it was because of some syndromes of sudden death. And so it's a medication that is much more carefully used nowadays in agitation. Still used, and psychiatrists will use it judiciously at the right dosing. But there are some medicines that are clear problems in the geriatric population, and some that need a trained hand. Certain medications, for example, some of the older tricyclic antidepressants are highly anticholinergic. And anticholinergic medications can really have a challenge for geriatric population because often their cholinergic neurons are just not producing as much, and it's one of the most common pathways in neurotransmission for certain dementias, including Alzheimer's. So we're careful to use those, and often they have fairly high side effects.
Right.
Medications that have long half-lives.
So a Prozac versus a Zoloft.
And so knowing for example, how to dose that, there have been good studies to say that sometimes Prozac is useful in the geriatric population because they often miss a dose or skip a dose. But it's the kind of thing where you might dose them only once every couple of days, and then the half-life is long enough. Or a patient that is often non-compliant, you might give them Prozac. But again, it's understanding it and being more careful and giving a lower dose. Absolutely.
Are there certain baselines that you start with? Say a Zoloft. Say you would start somebody 25, then increase it to 50 maybe in 14 days, seeing if they're doing well. Is there a point where, I guess with metabolism and things like that, do you have to wait a little longer for geriatrics to see if there's side effects, or if it's...
In the geriatric population, there are certain medications that are generally fairly safe, and there are others that aren't, and you need to be a little bit more careful. Take something like Zoloft. You might want to start a lower dose than you might with an adult who's under 65. You also have to take a look at your patient. Is it somebody who is a very robust 65-year-old, or are you treating a very frail 80-plus-year-old? There's a big difference. And as the geriatric population is getting older, that there's almost subpopulations within the context of geriatrics, but it's good to start thinking about, do I need a lower dose? Also, to get to steady state might take a little bit longer because they have a longer half-life for some of these medications. And there's great resources on the internet for what happens when somebody has renal or hepatic changes, and being able to look at very quickly, what do I do for geriatric patient or for a patient with renal and hepatic changes, and being able to think, well, this is a medication that I'm going to assume that my geriatric patient has some changes in those organs. So here's where I'm going to start the dose, and I'm going to increase it more slowly and look for positive or negative effects a little bit more frequently.
Do you tend to do labs more in the geriatric population versus the general adult population, or how does that vary, or is it just case-by-case basis?
I think it is a case-by-case basis, but I think it also is a disease-by-disease basis as well, so that if I'm looking for medical causes of a problem, I'm obviously going to do a flurry of labs in the beginning. But if I find a patient is generally stable and at their baseline medically, most of the lab work isn't going to change a lot unless it's something that you're using that can easily change and has a very narrow therapeutic window. So I might do lithium levels more frequently in the geriatric population because it doesn't take a lot of changes in their kidney function to make a lithium level go quite high. Right. At the same time, will I look at thyroid function more frequently in that population? Probably not. No more often than a typical geriatric that you would do for labs.
Yeah, I imagine it's very complex when you've got so many physical ailments and they're being treated with so many different medications. Choosing a medication that's not going to interfere, or I guess with the cytochrome P450 enzyme and all of that, it's almost like you're putting a puzzle together.
And interactions are very important to look at in the elderly population because they are on so many different medications. It's important to use medications that generally have low interaction in the geriatric population and looking at their medications in general. One, again, both handheld and on the web, there are great things to put a set of medications in and then put your medicine in and see if it interacts. The other is to know which ones have more of an effect on the cytochrome P450 system. So, for example, if I'm looking at antidepressants, bupropion doesn't have a lot of effect on the cytochrome P450 system. Paxil has a tremendous effect on the cytochrome P450 system. Celexa and Lexapro, citalopram and escitalopram have a fairly low effect on the cytochrome P450 system, or it's fairly even, which means it uses multiple doors to do its metabolism, which means it doesn't use up just one channel, which means it won't make one medicine accumulate. Something like Prozac has a fairly large effect on just one channel, which means if any other meds are going through that same cytochrome P450 system channel, it can be blocked off because which means that other medicine might accumulate. And that's one of the things we've been talking about is accumulation of medicine can make behavioral changes. So you're trying to treat one thing, you end up making something else worse, and then you're chasing your tail, so to speak.
But sometimes good things happen,
Yes.
and you see a stark change and the return of cognition and no more altered mental status and things like that. From a We talked a little bit about, and I think it's a difficult topic, is dealing with combative patients, especially some that have never been combative before, and to see a little old lady start to swing on people or trying to throw items. What's the best way to kind of de-escalate some things like that in your experience?
I've had a really um, set of positive experiences in a number of nursing homes where I have seen combative patients, asked to see them, um, sometimes look at the causes, sometimes look at medications that might work. If you've done your due diligence, you've done the diagnosis, you figured out what was going on, you figure out, is this acute or a more chronic illness? Is this going to need certain kinds of temporary treatment or more consistent treatment for the combativeness? There's a couple of things once you've done that you can do to help with the behavior, because obviously combativeness can hurt both the patient and the staff members that are trying to take care of them, and it's probably or family members, and it's probably one of the most difficult things to deal with. In that realm, there are some medications that can be used, but the first things that are used are behavioral. Orienting somebody has a tremendous effect on
kind of bringing them back to the moment.
Well, not only maybe bringing them back to the moment, but telling them that they're safe, telling them that they're in the hospital or in a familiar place, or it's a familiar person that's taking care of them. Once they hear that it's safe and get that reassurance, there are some patients who will calm down because
So they could be panicking. A novel environment.
Exactly. Anxiety and the novel environment, especially if you are cognitively impaired, can really be disturbing.
Right.
If you could imagine yourself being woken up in a semi-drugged state in an unfamiliar environment, surrounded by people who you don't know, you might be really scared and you might do something.
Right.
But if you're then reminded you live here in this nursing home, that's your room, everything's safe and it's okay, that by itself might help.
Mm-hmm.
The second thing that can sometimes help is some firm but gentle voice, understanding where they're coming from, and staff safety, to where, yes, the person who is combative, but is also wheelchair bound and is only swinging in this area.
So you basically analyze the threat.
You analyze the threat. So it might be that it's quite combative, but it's not going to hurt the person
contained.
or themselves.
Right.
And as long as they're not bothered by somebody giving them a shot, or somebody taking blood, or somebody making them take a bath, that might be where they're fine most of the day.
And I think too, there's still people, and we all have a range of emotions, and we can be triggered by something, whether we recognize it or not. So it may just be something that's short duration, or just a normal outburst of frustration. And because, like you said, if you're taken out of your element and moved into another element, that can be quite concerning. That's why I think most people who go into nursing home settings should probably be evaluated for depression, adjustment issues, being moved out of the home, loss of freedom. I just think that could go a long way too.
And when those behavioral treatments work, or work partially, but there's still some threat both to the patient and to others, then it's important to start to look at medications in a algorithmic approach that looks at the safest, least um, dangerous medications, try to find something that could work, um, that will help the patient and yet give them the least amount of side effects. Often, as an example, patients will have a little bit of combativeness in the evening, and in the nursing home, we found that low-dose trazodone, just for those particular patients, could often work very well. And some of it was just, wouldn't think of that. But they would often sleep, they would do well, and it initially gave them some calmness. The same with some of the antidepressants, even if it didn't specifically look like depression, often were very safe, effective medicines that sometimes might have been treating a masked depression, or it might be that there's an imbalance of inhibitory neurotransmitters like serotonin, and an SSRI can be really quite helpful. Buspar also, interestingly enough, can be helpful for some of these patients. At some point, even those don't work, and you start looking at things like benzodiazepines or antipsychotics. Short half-life, low dose, reasonable duration, taking them off as quickly as possible if it can happen, is the best initial approaches, with the idea that there are some patients that don't fit in immediately to that, where they might need them chronically or they might need a higher dose, but don't immediately go to the adult 30-year-old psychotic patient in an ER dose that a lot of people have seen. So that most physicians, as an example, have worked in the ER, and so they have in their mind the dose of, oh, that's what I give to a psychotic or combative patient. Sure, but most of those patients are drug or alcohol addicted, or they have psychosis from things that affect younger people, and so the person's 20, 30, 40. That's a big difference than somebody who's 75, medically frail, and hasn't had these issues.
So one issue I think is, and it remains big, is the notion of polypharmacy. And I know you're one of the docs who attempt to find the most optimal range without introducing a number of agents. Obviously, you've seen patients who are on a number of medications, but not even approaching what you would deem therapeutic level. So taking a patient off and trying to reorganize medications, I'm sure that's not easy either.
Those can be very challenging patients, the patients with polypharmacy, because interestingly enough, many of our medications, when we give them, especially at low doses, and sometimes geriatric patients, because people want to try low doses, they throw a low dose medication on. And then when that doesn't work, instead of removing it, they'll add another low dose medication. And then they'll add another low dose medication with the belief that if I'm using low dose on a whole bunch of them, it'll be safe.
But how do you know what works?
That's not only is that correct, but it also is the idea that many of the medications start to show side effects, including they still have to be metabolized. So you're now using cytochrome P450 channels. You also have interactions, and those interactions are then letting certain medications accumulate. And the other is there are certain side effects that start at very low doses. There's certain medications that will give negative side effects to patients at a low dose without changing the behavior that you're looking to change.
So all you'll see is side effects. You won't get to the benefits.
You won't get to the benefits. So some of it is looking at, one, what's the safest medications that somebody's on, especially if they come to you with numerous medications, and what is it that you're trying to treat. And then I think a lot of times people are afraid to destabilize the patient, so they don't want to remove anything. But it's sort of like playing Jenga. You look for the loose block. So if you have they're on 5 different psychiatric medications, and one of them is 100 milligrams of lithium at night, and you know they're getting a 0.1 level, likelihood it's probably not doing anything. Do you know for sure? No. But that would be one you'd consider removing. Or if the patient doesn't particularly have psychosis and their agitation is low, but they have quite a bit of depression, you might make sure that you remove the antipsychotic that they were on to adjunct, which might not be particularly helpful. It's looking at that patient, looking at the set of
being a detective.
Medications and being a detective and paying attention.
Right.
The other there's a lot of resources out there, whether it's resources on the internet, whether it's resources from professional societies, whether it's just colleagues, being able to find out more about a particular issue. Sometimes it's just getting more educated.
Well, I think we're just about out of time, but I wanted to thank you so much for dropping by and sharing your wisdom and knowledge. Hopefully you'll come back and we'll start another conversation about another topic.
Well, it was
Sound
absolutely
good?
my pleasure. I really enjoyed it.
Thank you, sir.
Thank you.